Here's an overview of our objectives for this presentation. Just a couple announcements before we begin. I will be answering any questions about this presentation at the end. Any questions we're unable to get to will be answered in the Q&A document. And we also have a few interactive polls throughout the presentation. So if you have your manuals available, that's great. If not, no big deal. Just try to answer the best that you can. We'll start with reviewing some anatomy. According to NCI and Johns Hopkins Medicine, each breast has anywhere from 15 to 20 lobes, which contain smaller lobules. These lobules end in bulbs that are milk-producing in function. Connecting all of these structures together are the ducts. In between, fat fills the remaining space. Lymph vessels within the breast drain to the lymph nodes, and most of the breast cancers arise from the ducts or the lobules, which give name to ductal and lobular carcinoma. Lymphatic drainage from the breast is directed primarily to the axillary lymph nodes. Per AJCC, there are 3 levels of axillary nodes. Level 1 contains the low axillary nodes. These are located below the axillary vein on the lateral side. Level 2 is the mid-axillary nodes. These are located under the axillary vein and the pectoralis minor muscle. And level 3 is the high axillary or apical nodes located underneath the collarbone and axillary vein. These may also be referred to as infraclavicular. The intramammary nodes are interspersed within the mammary tissue, and those are included in the regional lymph node staging. And finally, the supraclavicular nodes are located above the collarbone, and those are the highest level of regional lymph nodes metastasis. Here are some incidence rates of breast cancer from the American Cancer Society and NCI. Breast cancer is the second most common cancer in women within the US, second only to skin cancer. It's also the second leading cause of cancer deaths. Breast cancer deaths have declined by 44% since 1989, and this is through 2022. However, African Americans have the highest mortality rate from breast cancer, with a rate that's 41% higher than white women. This is thought to be due to a higher incidence of triple-negative breast cancer. American Cancer Society estimates that there will be 316,950 new cases of invasive breast cancer diagnosed in 2025 and 59,080 new cases of DCIS. Breast cancer can also occur in males, but occurs at a much lower incidence rate. The rates we see here are for women only. The 5-year relative survival rate is 91% for all of the SEER stages combined for the American Cancer Society. Localized disease survival rate is 99%. But that does not include in situ. Triple-negative and inflammatory breast cancers do have different survival rates. Overall, incidence rates have increased by 1% per year. However, the increase per year in women under 50 is 1.4%. According to the American Cancer Society and NCI, risk factors for breast cancer include lifestyle risks such as obesity, tobacco use, and alcohol use. Dense breast tissue. This tissue type makes it the interpretation of any abnormalities difficult on a mammogram because they would both appear white on the image. And age. Within the next 10 years, 30-year-olds would have a 1 in 175 chance of a breast cancer diagnosis, while 70-year-olds would have a 1 in 9 chance. Personal history of breast cancer or benign breast disease and family history of breast cancer in a first-degree relative are also risk factors. And then the inherited syndromes and genes such as the BRCA1 and 2. Let's look at how breast cancer is typically diagnosed per the NCCN guidelines. Breast cancer screening is done by mammograms, and the patient's risk level drives the age and the frequency of the screening. Patients that have an average risk begin annual screening at age 40 and above. For those that would have an increased risk due to family history, they will begin screening at an age that's about 5 to 10 years prior to when the youngest family's member age of diagnosis was. High-risk patients may also undergo screening by MRIs. If there is a finding on the screening mammogram, the patient goes on to have a diagnostic bilateral mammogram and an ultrasound. The patient may also present with a palpable mass and then go on to have workup. Core needle biopsy is performed onto a calcification or a mass. These can be done by ultrasound, mammogram, also called tomosynthesis, or MRI. If there is a clinical suspicion for lymph node involvement, FNA of the enlarged nodes may also be done. ER/PR and HER2 testing will be performed on the biopsy specimen in order to assign the prognostic clinical stage. After diagnosis, the patient goes on for further workup. This includes additional imaging by MRI if it's indicated or if it was not done as part of the screening. A PET CT may also be performed if there are signs or symptoms of metastatic disease or if the patient would be high risk. After imaging workup is complete, the patient will go on for consults and the physicians will assign a clinical stage. If the physician staging was not mentioned or was incomplete, the registrar must assign the clinical stage using HACC. Treatment planning may be done by a medical oncologist and/or a surgeon. The treatment plan is based on the histology, clinical stage, and NCCN guidelines. Primary site is determined by the clinical workup. The breast solid tumor rules provide some really great resources. Table 1 includes common site descriptions and which site code should be assigned. This table also includes directions for coding overlapping and NOS subsites within the breast. The clock diagram that's shown on the right is included under the illustrations of the breast solid tumor rules, but can also be found in the SEER Appendix C breast coding guidelines. Okay, here's our first primary site scenario. The patient has a palpable breast mass located in the upper outer quadrant with diffuse involvement of all quadrants stated to be suspicious for inflammatory carcinoma. How would we code the primary site?
Okay, it looks like just about everyone has voted. About 60% is saying C50.9, 20% is saying C50.8, and 22% are saying C50.4.
Okay. So the answer is A, C504, upper outer quadrant. Per the SEER Manual 2025 and the Breast Solid Tumor Rules Table 1, we code the subsite for the breast for the position of the palpable mass with inflammatory carcinoma. C509 would be used for inflammatory carcinoma if there was no palpable tumor. And there's also a link to a SEER sync post below that was discussing this as well. According to Johns Hopkins Medicine, the most common type of breast cancer is invasive ductal carcinoma, which comprises about 80% of the diagnosed breast cancers. This also includes carcinoma NOS and mammary carcinoma NOS, which are assigned 8500/3 per the breast solid tumor rules. Invasive lobular carcinoma makes up about 10 to 15%, and the remaining percentage is the other special types such as mucinous, medullary, micropapillary, papillary, and tubular carcinomas. And these are images below are what these histologies look like under the microscope from Johns Hopkins. Here's a common histology scenario that can be tricky when moving through the breast solid tumor rules. Which histology should be assigned for a breast tumor located in the left inner quadrant with the pathology showing infiltrating duct carcinoma and an additional finding of lobular carcinoma in situ or LCIS? We have A, 8500/3, B, 8522/3, or C, the two primaries with sequence 01 of 8500 and sequence 2 of 8520.
Okay, it looks like voting has slowed down. So 46% say 8500, 40% say 8522/3, and 13% are going with two primaries.
Okay. The answer for this question is B, 8522/3. So using the single tumor, invasive, and in situ component section, at first glance, H27 seems to apply. However, if we look at the exception, it states continue through the rules when there are multiple tumors of ductal and lobular carcinoma with different behaviors. In H28, we're instructed to code ductal and lobular 8522/3 when the final diagnosis is any of the following, and this contains our scenario of infiltrating duct carcinoma and LCIS. There were some histology changes in the breast solid tumor rules for version 24 that began with cases diagnosed 1/1/2024 forward. The in situ lobular mixed with other types of in situ carcinoma was previously coded to 8524/2, has been deemed biologically impossible per cancer path chart review. And the solid carcinoma or solid adenocarcinoma was previously 8230, will be now assigned as 8500/3. For 2025, Table 3 was just updated a bit. There were new rows added for neuroendocrine carcinoma NOS with subtypes and variants, and the small cell carcinoma was moved to this new NEC row. Within the metaplastic carcinoma NST or NOS, the code for low-grade adenosquamous carcinoma was corrected to 8570, and a new subtype, a variant of epithelial myoepithelial carcinoma, 8562, was added to the adenomyoepithelia carcinoma row. There are specific grade instructions in the grade manual for cases diagnosed 2018 and forward. Per note 4 in the breast grade table, there are two major grading systems used for breast, and they are based on the behavior of the primary tumor, in situ or invasive. The in situ tumors use a 3-grade nuclear system, and they're defined as low for nuclear grade 1, intermediate for nuclear grade 2, and high for nuclear grade 3. And documentation for these grades on the path report might be listed as 1 out of 3, 2 out of 3, or 3 out of 3, but this is not documenting a Nottingham grade. The invasive tumors use the Nottingham grade system, which is also known as Scarf-Bloom-Richardson or Bloom-Richardson. And this grade is derived from a 3-component score to give a combined scoring grade. Grade 1 is score 3 through 5, grade 2 is score 6 through 7, and grade 3 is score 8 through 9. Let's take a look at this case for our next scenario. On 3/1/2025, a right breast 12 o'clock biopsy has pathology showing DCIS nuclear grade 2. On 4/15/2025, the right breast lipectomy shows invasive ductal carcinoma, 2 mm focus, Nottingham grade 2, with the residual DCIS in nuclear grade 2. So how should we assign grade for this one?
Everyone voted pretty fast for this one. Some are still coming in, so we'll give it a few more minutes, but if you haven't voted, go ahead and do that. We're going to close it out in just a few more seconds here. And if you don't have the manual up, it's absolutely okay to go ahead and vote anyway. See if you know off the top of your head. We should always use the manuals, but in this scenario, just see if you have that information. Store it away there. Looks like we have close to 900 people on, but we only have about half voting here. Okay, let's close it out. We have, before we close that, I'll just give you the information here, Kelsey. 14% said A, 30% said B, and 56% said C.
All right. The answer for this one is C, clinical grade M, path grade 2. Our biopsy showed the in situ disease of nuclear grade 2, and then the lipectomy showed the invasive disease with the Nottingham grade 2. The grade manual note 5 says do not use grade LMH for invasive tumors, but has the exception that if the biopsy diagnosis is DCIS and the resection is invasive, clinical grade would be assigned M based on the DCIS, and the path grade would be based on the invasive. Your behavior would still stay at the /3. Next, we're going to go through an overview of AJCC staging. The AJC Online Principles of Cancer Staging gives a general instruction for the clinical timeframe. This includes all information from the date of diagnosis before the initiation of primary treatment or treatment decision up until either 4 months after diagnosis or disease progression, whichever is shortest. And then from the breast section of AJCC Online Clinical Classification, the imaging is not required to assign the clinical stage, and biopsy from lymph nodes or metastatic sites can be assigned the clinical stage. The CN suffix F is used when the regional lymph node biopsy or FNA is performed during the clinical time frame. And the positive microscopic confirmation of distant mets is assigned as PM1 and qualifies for both clinical and path staging. The pathologic timeframe per AJCC online general instructions includes clinical staging, operative information, as well as the surgical resection within that 4 months after diagnosis, up until adjuvant treatment or disease progression. For the breast section for pathologic stage and AJCC, this would include all the clinical data, surgical resection, both operative and pathologic findings of the primary tumor and regional lymph nodes. Resection of the primary tumor is required to assign the PT, and there must not be macroscopic residual at the margin. So that would be residual that you can see with the naked eye. When should a suffix be used when assigning AJC stage? Per the general instructions from AJCC, the M suffix is used in the T category to denote multiple tumors in a single organ that are abstracted as a single primary. Take note, though, the M suffix applies to multiple invasive tumors only. It does not include multifocal in situ or a mixed invasive or in situ cancer. The F suffix is used to denote the biopsy or aspiration of regional lymph nodes. The lymph nodes may be negative or positive on path. This is only recording that the nodes were evaluated by a biopsy or aspiration. The SN suffix is used when only a sentinel lymph node biopsy is performed. Sentinel and additional non-sentinel nodes may be removed, but if an axillary dissection was also performed, the PN suffix will be blank. YC versus YP staging. YC and YP staging are the stages assigned after a patient has completed the full course of neoadjuvant treatment. YC stage is assigned from restaging information, typically imaging, and this can be used in situations where the planned post-neoadjuvant surgery is canceled. This could be because the patient didn't respond, there was disease progression, or if they had a complete response and the physicians feel that surgical resection is no longer needed. YP stage is assigned from the planned post-therapy surgery. The surgery would be completed as planned. Only one of these stages is required once neoadjuvant therapy has been completed per AJCC, and the stage group will be assigned as 88, not applicable. These cannot be assigned a stage group because there's not a prognostic stage group table for us to use. In this scenario, we're going to review a nuanced staging situation. A patient is diagnosed with breast cancer and undergoes a mastectomy with a sentinel lymph node biopsy, which diffusely involves the right breast. PET scan was not performed until after surgery, which noted a hypermetabolic intramammary lymph node that was stated to be metastatic. Intramammary lymph node was not sampled due to the patient's choice. How should this lymph information be captured within the AJCC staging? What's the time frame, and can the information after treatment be included in staging? To answer the first question, what is the time frame? The window from the clinical time frame closed when treatment began with a surgical procedure. This node, although detected by imaging, was not found during the clinical workup, so we cannot apply it to the CN. Can the information after treatment be included in the staging? Per AJCC Chapter 1, or the online version of the principal cancer staging, imaging studies that are done after surgery are included in pathologic staging if they are within the time frame or the staging window. For the breast chapter, the PN assignment requires confirmation of only one lymph node. The involvement of the intramammary lymph node will be assigned in the PN category as PN3. There is one staging discrepancy between the standard setters. When there's involvement of the supraclavicular lymph nodes, AJC assigns these as N3. SEER includes these within the EOD regional nodes code 700. However, this does upgrade the SEER summary stage 2018 to distant. This graphic just shows a breakdown of the major SEER summary stage groups using the 2018 manual, and there's many helpful coding notes within the manual, especially for regional by direct extension. The localized disease is that it's confined to the primary breast tissue and the fat, but it also would include the Paget's disease. Regional by direct extension covers the involvement of the rest of the breast, which would include attachment, fixation, chest wall involvement, extensive skin involvement, with or without a stated diagnosis of inflammatory carcinoma. The regional lymph node category would include the axillary levels 1 through 3, ipsilateral internal mammary and intermammary nodes. And then distant disease would be the infraclavicular and supraclavicular nodes, as well as any contralateral or cervical nodes. And that would also include any skin involvement of the contralateral breast, satellite lesions of the skin and other sites, and of course, any metastatic disease to distant organs. Inflammatory breast cancer is a rare and aggressive type of breast cancer according to NCI. It's characterized by diffuse erythema and edema, often called port orange, which involves 1/3 or more of the skin of the breast. Symptoms develop due to blocked lymph vessels within the skin of the breast by tumor emboli. Typically, a clinical diagnosis is made by physical exam and imaging. True inflammatory carcinoma is a rapid development from the first symptom of diagnosis to a time frame of less than 6 months. This designation is not given to cases of neglected locally advanced cancer that has progressed to the late stage of disease. The slide shows the staging criteria for HACC and SEER, and there are just some slight differences here. Per HACC, the inflammatory carcinoma is primarily a clinical diagnosis and is assigned a CT4D. It's identified by the diffuse erythema and edema, POTA orange, involving approximately 1/3 or more of the skin of the breast. Imaging may show a detectable mass and skin thickening over the breast. However, an underlying mass may or may not be palpable. A tissue diagnosis is required to demonstrate that there is invasive carcinoma within the parenchyma of the breast or the dermal lymphatics. The tissue diagnosis is also important to obtain the ER, PR, and HER2 and the grade to assign the prognostic stage group. Again, this category can only be used if the onset of symptoms is rapid, 6 months or less. SEER collects the staging information of inflammatory carcinoma within EOD primary tumor and the SEER summary stage. Inflammatory carcinoma is collected in codes 450 through 600, and the assignment of these is dependent on the percentage of the involvement. Let's look at a case study for inflammatory breast cancer. A 61-year-old married white female presents to the facility on 6/5/2025 for a mammogram after complaints of a skin rash developing over the left breast over the last month. Physical exam by Dr. John Smith on 6/20/2025 shows a left breast rash, swelling, induration, and nipple inversion. Mammogram findings are suspicious for inflammatory breast cancer. Biopsy confirms malignancy and patient undergoes neoadjuvant treatment at an outside facility. Patient returns for a radical mastectomy. In the imaging we have on 6/5, the mammogram shows the ill-defined mass in the upper outer quadrant, associated nipple retraction, skin thickening, left axillary lymphadenopathy, highly suspicious for inflammatory breast cancer. Ultrasound demonstrates extensive skin thickening in all 4 quadrants, an upper outer quadrant mass that measures 3.2 centimeters at the 230 position. Left axilla reveals abnormal lymph nodes suspected metastatic adenopathy. A PET CT was done that reveals known biopsy-proven carcinoma in the left breast with suspicious metastatic axillary adenopathy, osseous lesion suspicious for METS, and the pathology shows invasive carcinoma NST, Nottingham grade 3, ERPR negative, HER2 positive from the biopsy. On resection after the full course of neoadjuvant treatment, there is residual invasive carcinoma with ulceration, Nottingham grade 3, on the mastectomy with 4 out of 6 sentinel lymph nodes positive for METS. We have some staging by the medical oncologist who clinically stages as CT4, CN2, CM1 with the ERPR negative, HER2 positive, and the YP stage as YPT4B, YPN2A, SN, CM1. We have 2 examples of text in this case study. Now let's place ourselves in the position of the second reader. So you are reading this text having no access to the EMR. Text example 1, we have exam text 61 married white female presents to facility for mammogram, finding suspicious for breast cancer, biopsy confirms malignancy, and patient undergoes neoadjuvant treatment at outside facility. Patient returns for the radical mastectomy. In the staging text, we have CT4, CN2, CM1 stage group 4, YPT4B, YPN2A-SN, CM1, ERPR negative, HER2 positive, stage 88, SEER summary stage 7. From just reading this text alone, do we have much to support the T4 stage and where the stage is coming from? No, we're not sure if this is a physician stage or if there was a physical exam that would allow us to assign a more specific T subcategory. Let's review text example 2. Exam tech 61 married white female presents to the facility on 6/5/2025 for a mammogram after complaints of a left breast rash, swelling, induration, and nipple aversion. Mammogram findings are suspicious for inflammatory breast cancer. Physical exam by Dr. John Smith on 6/20/2025 shows ulcerated, potent orange skin of the left breast, suspicious for inflammatory breast cancer. Biopsy confirms malignancy, and patient undergoes neoadjuvant treatment at the outside facility. Patient returns for the radical mastectomy. In this staging text, we have Dr. John Smith, CT4, CN2, CM1, ERPR negative, HER2 positive 3+. For ODSC, CT4D, we have inflammatory diagnosis, clinical stage 4. So they completed that position staging. For Dr. John Smith, YPT4B, YP2N2A-SN, CM1, ERPR negative, HER2 positive. For ODSC, post-therapy past stage 88, SEER summary stage 7 for the bone mets per the CT. So from this text, we have both the position stage and the registrar's components. We also have documentation of the physical exam showing the inflammatory carcinoma clinical diagnosis and how much tissue was involved, which allowed the registrar to more specifically assign clinical stage as CT4D. We feel confident as a second reader that this is accurate without being able to verify with the EMR. This is why texting the physical exam and supporting the stage text is so important, not just inflammatory cases, but in all breast abstracts. Next, I'm going to go over an overview of some of the updates to the SSDIs in the most recent versions. Estrogen receptor positivity and progesterone receptor positivity are favorable prognostic factors in breast cancer. Positive results would predict a favorable response to endocrine hormonotherapy, and combined ERPR positivity is associated with an increased response to anti-estrogen therapies. These values can vary on how they're reported. The actual percentage takes priority over a range if it's given. If you have an ERPR given in a range that's not defined within the SSDI codes, we're instructed to code the range that contains the lowest number of the range that was provided, if that's less than or equal to 10. So for example, if we have ER 25 to 50%, use code R30 as 25 is the lowest number of a range in the 20 to 30% range, code R30. This instruction was added to the 2022 SSDI manual, and there's also a cancer forum post that we can link below. We'll go over a quick refresher of some of the SSDI rounding rules with some examples. All SSDIs have lab values, percentages, or measurements that are set to record in the tenths, which is 1 digit after the decimal point. If a lab value, percentage, or measurement is recorded in the 100ths, which is 2 digits after the decimal point, the last digit must be rounded. One more or one less may refer to a whole number, such as 1, or a decimal 0.1, depending on the structure of the SSDI. We can see that when key 67 is stated as greater than 25%, it's recorded as 25.1 for one more digit than the last based on this coding structure. The ERPR percent positive do not have decimal points, so any labs given with the decimal would have to be rounded, and they would be rounded by the last digit, the decimal, up to the next whole number. Instructions for ranges were updated in the SSDI manual version 3.1 to record the next highest number based on the lower value. Depending on the SSDI, this may be a whole number or a decimal, similar to the greater than values. Here's an SSDI scenario. The pathology report from the breast biopsy reads invasive ductal carcinoma, Nottingham grade 2, no LBI. An addenda with further testing shows the ER is 90 to 95% positive, PR is 30 to 35% positive, and HER2 IHC is -1+. Key 67 is greater than 50. So let's code these SSDIs together. The ER percent positive will be R90. The range from 90 to 95% is less than or equal to 10. So we take the lower number, 90, and code the range value for where that falls, which is the R90 range, 81 to 90%. ER summary would be coded to 1 for positive. The PR percent positive will be coded to R30. Again, the range here is less than or equal to 10. So the lowest value of 30 falls within the 21 to 30% range of R30. The PR summary is coded to 1 for positive. HER2 overall summary would be 0 for the negative HER2. and the Q67 is coded to 50.1%. We were given a greater than, so we have to round up, and since this STI has a decimal, we go up by 0.1 more than the last digit. New surgery codes were introduced for cases diagnosed 1/1/2024 forward. These are located in the STOR Appendix A in SEER 2025 Appendix C. This first table summarizes the breast conserving surgery, which would include the partial breast surgery, excluding central. So these would be the lumpectomy, segmental mastectomy, partial mastectomy, quadranectomy, and tylectomy, with or without the nipple, are all bundled together under the B200 code to use when there was a previous positive biopsy. Central lumpectomy for prior positive biopsy removes the nipple areolar complex and is coded to B290. We could use this with Paget's disease. Excisional biopsy codes were used for previous atypia, such as ADH. B210 would be used when there's an excisional biopsy for diagnostic purposes and there was no preoperative biopsy. And B215 is used when there's a previous biopsy positive for ADH. The re-excision of the primary tumor site for gross or microscopic residual disease is when there is less than a total mastectomy performed, and coded to B240. For the mastectomies, we have the skin-sparing mastectomy, which will remove all breast tissue and the nipple areolar complex, but preserves the native breast skin. These are coded under the B300s. The nipple-sparing mastectomy removes all breast tissue, but preserves the nipple areolar complex and the breast skin, coded to the B400s. Areolar sparing removes all breast tissue, and the nipple preserves the areola and breast skin, under the B500s. And the total or simple mastectomies removes all of the breast tissue, the nipple areolar complex, and the breast skin. These are coded in the B600s. These codes are also used for a modified radical mastectomy, and this was a change as they used to be coded separately prior to 2024. All of the mastectomies from code B300 to B600 categories may be performed with or without a sentinel lymph node biopsy or an axillary lymph node dissection. Radical mastectomy removes all breast tissue, the nipple areolar complex, breast skin, and the pectoralis muscle, and it's performed with a level 1 through 3 axillary lymph node dissection under B700. A bilateral mastectomy for a single primary involving both breasts, such as for inflammatory carcinoma, is coded to B760. Extended radical or a mastectomy NOS is coded in B800. And just a final note that reconstruction is no longer included within the surgery codes. Instead, these are collected in the hospital and summary breast reconstruction fields, which leads us to our next slide. The information for coding reconstruction is located in the STOR coding manual, and there are two fields, the RxHosp Recon Breast and the Rx Summary Recon Breast. The reconstruction codes do include informal reconstruction, such as a mastopexy or rearrangement of tissue. And keep in mind that these fields collect immediate reconstruction done on the ipsilateral breast only. These codes will not be changed if there's additional reconstruction done in a different procedure later on. These data items were required for breast cases diagnosed 2022 and forward, but they were updated in 2024. For lymph node surgery, we have a sentinel lymph node biopsy or an axillary dissection. The sentinel lymph node biopsy is typically done for patients that are clinically negative for lymph nodes, and the procedure is done to identify any of the draining or sentinel lymph nodes and remove them. If a sentinel lymph node biopsy is done, the patient will have had lymphatic imaging or mapping, usually done on the day of surgery. And you may also see on the operative report that the neoprobe was used to locate the sentinel lymph nodes. If extra nodes or incidental non-sentinel nodes are present in pathology, we will not use the axillary node dissection. We only code the intent of the surgery, which was the sentinel lymph node biopsy. Axillary lymph node dissections will usually be done for lymph nodes that are palpated or clinically seen on exam. They may be done if the sentinel lymph nodes cannot be identified or if they were positive on frozen section. The entire level 1 and 2 chains will be removed from the anatomical triangle. This is the axillary vein to the chest wall and latissimus dorsi. A targeted axillary dissection can be performed for node-positive patients that have undergone neoadjuvant therapy. The aim is to decrease unnecessary axillary lymph node dissections for those that have had an excellent response to neoadjuvant therapy, and they should be treated as node-negative patients. The axillary contents are spared to improve quality of life and avoid lifelong lymphedema, which is the buildup of lymph fluid between the skin and the muscle. Some tips to identify these are to look for a placement of an I-125 mag seed and a node marker. The use of probes to locate those nodes. They may be stated as a dual probe, one for the sentinel lymph node and one for the mag seed. Nodes are selectively removed and then done with a sentinel lymph node biopsy. These nodes may be referred to as cold. To identify a true axillary lymph node dissection, level 1 and 2 nodes within the anatomical triangle would have to be removed. I've also included a link at the bottom of the slide with a posting describing this procedure in more detail. Let's work through some lymph node case scenarios. First one, we have a 67-year-old divorced white female prevents for surgery of a biopsy-proven invasive ductal carcinoma, grade 2. In the surgeon's operative notes, it states the planned procedure is a partial mastectomy and sentinel lymph node biopsy. However, in the detailed description, the surgeon notes the sentinel lymph node failed to map. Dye was injected, the incision was made, and they attempted to locate the sentinel nodes, but none were found. The axilla incision is made and exploration is documented. No nodes were resected, and the partial mastectomy was completed as planned. The pathology report confirms no presence of regional nodes. How do we code the situation when the sentinel lymph nodes failed to map? Surgery primary site will be B200 for partial mastectomy. Per the op note, the planned procedure was a partial mastectomy, and this was completed as planned. Scope of regional lymph node surgery will be 2 for the sentinel lymph node. We're coding the intention of this procedure. RX summary reconstruction will be a 000 for reconstruction was not mentioned. Sentinel lymph nodes positive will be 98, and sentinel lymph nodes examined will be 00. PN suffix will be blank. No sentinel lobes were removed or examined, so per AJCC, this will remain blank. The date of sentinel lymph node biopsy, this field is also blank. Per the SEER 2025 manual, page 192, item number 6, when the sentinel lymph node biopsy was attempted or failed to map, we leave this blank. Date of regional lymph node dissection is also blank, and the regional nodes positive and examined are 98 and 00 because no nodes were examined. Lymph node case scenario 2. 42-year-old married Black female presents with a palpable left breast bump along with papillary axillary nodes on the left. Biopsy was positive for invasive ductal carcinoma of the left breast, grade 3, ERPR negative and HER2 positive. Axillary lymph node FNA was performed and was positive. Workup shows no evidence of metastatic disease. The patient undergoes neoadjuvant systemic treatment with an excellent response, and then undergoes a bilateral total mastectomies with abdominal deep flap and targeted axillary lymph node dissection on 10/1/2025. Maxi clip was placed in the previously biopsied node. The op report shows that the surgeon used a neo-gamma probe and sentinel mapping was performed. The entire breast, chest wall, supra and infraclavicular and axillary nodes were mapped with no hotspots. The Maxi probe showed high signal in the left axilla. A cold, firm node was taken, and the next lymph node was a clip that was dissected. Third and fourth cold firm nodes were present and removed. None of the nodes had blue dye. Pathology shows no residual tumor in these 4 nodes, and the pathologist states that the sentinel nodes examined and assigns YP N0SN. How do we code a targeted axillary dissection? Surgery of the primary site will be B620 for total bilateral simple mastectomies. Scope of regional lymph node surgery will be 2 for sentinel lymph nodes. We want to avoid running with that dissection term. The targeted dissection terminology mentions the MAGC placement and the neoprobe, along with the pathologist calling these sentinel nodes are clues to keep this coded as a sentinel lymph node biopsy. The RX summary reconstruction will be A610 for the mastectomy reconstruction with abdominal tissue. This was the abdominal deep flap per the STOR manual. Sentinel lymph nodes positive will be 00, and sentinel lymph nodes examined are 04. YPN suffix is SN. We coded the procedure as a sentinel lymph node biopsy, and the pathologist also listed that the sentinel lymph nodes were examined. Date of sentinel lymph node biopsy is 10/01/2025. Date of regional lymph node dissection is blank, and the regional nodes positive are 00 and examined are 04. Lymph node case scenario 3. 53-year-old married Hispanic female with biopsy-proven invasive ductal carcinoma, grade 3. No palpable nodes were found during clinical workup. She presents for surgery on 7/3/2025, and the operative note states that the planned procedure is bilateral skin-sparing mastectomies and sentinel lymph node biopsy. The detailed note states 2 hot blue sentinel nodes are identified, removed, and sent to pathology. Gross section showed that 2 out of 2 lymph nodes were positive. Decision was made to perform a completion axillary dissection. Bilateral skin-sparing mastectomies with tissue expanders completed as planned, and the pathology report shows 2 out of 2 sentinel lymph nodes positive and 1 out of 15 non-sentinel nodes positive. So let's go through the coding of this one. Surgery of the primary site will be B320 for bilateral skin-sparing mastectomies that were completed as planned for the op note. Scope of regional lymph node surgery 6, both the sentinel node biopsy and completion axillary dissection were done in the same procedure on the same day. The RX summary reconstruction is A100. Tissue expanders were placed without the implant or tissue for immediate reconstruction per store. Sentinel lymph nodes positive is going to be 02. This was a change in store 2025. If the number of positive sentinel lymph nodes are provided on the path report, then we capture the number. We're only going to use code 97 if the number positive was not provided. And the reason for this change was just to remove outdated CAP information. Sentinel lymph nodes examined will be 02 for the 2 sentinel nodes that were removed and sent to pathology. The PN suffix will be blank. Although a sentinel lymph node procedure was done, a completion axillary dissection was also done to complete the PN staging. The date of sentinel lymph node biopsy and date of regional lymph node dissection are both going to be 7/3/2025 since both were done. And the regional node positive will be 03. This records the total number of positive lymph nodes from both the sentinel lymph node procedure and the regional dissection, and 17 nodes are examined. Chemotherapy is typically given to patients as neoadjuvant treatment. The treatment goal may be to help facilitate breast conservation therapy. Per the NCCN guidelines, this is indicated for lymph node positive patients. The most common regimens include adriamycin and cyclophosphamide for 4 to 6 cycles, followed by paclitaxel, taxotere and carboplatin, taxotere, adriamycin, and cyclophosphamide. And some chemo agents or regimens may be given as adjuvant treatment as indicated by the NCCN guidelines. Adjuvant radiation therapy is indicated for patients after breast conserving surgery and for patients with lymph node positive disease, or if there are positive margins. It's also indicated when there is chest wall extension. NCCN guidelines indicate whole breast radiation plus or minus a boost to the tumor bed. Accelerated partial breast irradiation, or APBI/PBI, may be considered for patients who are low risk. Radiation therapy may be omitted for node-negative, hormone-positive patients if endocrine therapy is planned and the patient is greater than or equal to 70 years old, clinically node-negative, and PT1 on surgical pathology, or if the patient is also greater than or equal to 65, pathologically node-negative, and the primary tumor is less than or equal to 3 centimeters on surgical pathology. Here is a radiation coding scenario, and this is our radiation treatment summary. 3/4/2025 to 3/25/2025. Treatment directed to the right breast with 6x photons, IMRT, 4,256 centigrade and 16 fractions, 266 centigrade per fraction. And 3/26 to 4/1, the boost was given to the lumpectomy tumor bed with 6x photons, IMRT, 1,000 centigrade and 5 fractions, and 2,000 centigrade per fraction. The total dose summary is 5,256 centigrade and was completed as planned. I'm going to try to select the correct primary treatment volume for phase 1 and phase 2. Oh, here we go.
We'll give about another minute for this. Okay, looks like voting is slowing down, so I'm going to go ahead and end the poll. So we had about 9% say A, 84% say B, and 6% say C.
Okay, great. The answer is B, phase 1, code 40, and phase 2, code 41. Phase 1 is coded to the right whole breast, 40, and phase 2 is coded to the right partial breast, 41. This instruction is located in STOR page 258, as well as the STOR Appendix R case study 7. There's an exception to the rule for breast cancer. Patients who have had a lumpectomy, we code 40 when the patient has whole breast radiation. When the patient has a boost to the surgical bed, a new phase is started, and the primary treatment volume is only the surgical or tumor bed, which is coded to partial breast. As indicated in the STOR manual, there are many forms of radiation that may be done for breast cancer. We have the external beam radiation, and the primary treatment volume can be recorded as 40 for whole breast, 41 for partial breast, which would treat the boost to the lumpectomy bed, or APBI. Code 42 is used for chest wall. This code is used following mastectomy because all of the breast tissue has been removed. And then code 04 treats the axillary, supraclavicular, or intramammary lymph nodes as the primary treatment volume. And this can be done during a simultaneous integrated boost. We also have some options for IRRT, which is intraoperative radiation treatment. That's done by external beam. The lymph nodes are not targeted, and the planning technique would be 0-2 for photons. And then brachytherapy, such as SAVI, Mammocyte, or Contura MLB. The lymph nodes are also not targeted, but the planning technique is 88 per STOR. Hormone therapy is indicated as an adjuvant treatment for hormone receptor positive patients per the NCCN guidelines and American Cancer Society. Consideration is given to patients with breast conserving surgery and XRT, especially for ER positive DCIS. Hormone treatment could be contraindicated due to comorbidities. Tamoxifen would be given for 5 years for premenopausal women, and Arimidex is given for 10 years for postmenopausal women. The chart to the right shows a few different categories of hormone treatment and some common agents. The aromatase inhibitors work by reducing estrogen production. The selective estrogen receptor modulators and degraders, these agents work by preventing the estrogen from attaching to the cancer cells. And then a few agents that stop ovarian function are Zoladex and Lupron. Endocrine surgery with a bilateral salpingo-oophorectomy, or BSO, or endocrine irradiation work to suppress the naturally occurring hormonal activity. These procedures must be bilateral to be considered as treatment. If only one gland is intact, the remaining will qualify for treatment. An endocrine procedure is assigned as code 30 for STOR and SEER. The American Cancer Society notes that 15 to 20% of breast cancers produce too much HER2, which is a growth-promoting protein. Targeted therapy is given to HER2-positive patients. Herceptin and Perjeta, or both, can be administered, and both of these agents are coded as immunotherapy per SEER-RX. This may be given with chemotherapy or alone. These agents are typically given for a time frame of about 6 months to 1 year. But we've reviewed all of the treatment options for breast cancer. This brings us to our final case scenario. There's a 47-year-old single white female presents to treatment on 3/29/2025 who has a biopsy-proven, poorly differentiated cancer, most consistent with invasive ductal carcinoma grade 3. Ancillary studies show that the cancer is triple negative, so this is ER/PR negative and HER2 1+. PET CT shows a 3.8 centimeter mass involving the lateral right breast with no hypermetabolic lymph nodes or evidence of metastatic disease. The MEDOX stages as CT2, CN0, CM0, and the patient begins neoadjuvant pembrolizumab on 2/28/2025, followed by the chemo regimen of doxorubicin and cyclophosphamide. The full neoadjuvant course is completed. Bilateral total mastectomies with a sentinel lymph node biopsy are performed as planned on 9/2/2025, showing a complete response and no residual tumor. 6 sentinel lymph nodes were negative. There's no role for radiation or hormone therapy per the MD, and the patient restarts the pembro as adjuvant treatment. Okay, first we're going to go through the staging and coding of SSDIs. The ER summary and percent positive, so the ER was negative, so these will both be zeros. The PR was also negative, so these are both also zeros. HER2 summary was 1+, we code that as -0. The lymph nodes positive, axillary level 1 through 2. There were 2 sentinel lymph nodes that were negative on resection, so we can code 0, In the response to neoadjuvant therapy, there was a statement of complete pathologic response for the MEDONC, and we code this as 1. For HACC staging, the clinical stage assigned by the MD was CT2, CN0, CM0, and the registrar assigned the stage group as 2B based on the clinical prognostic staging table for triple-negative grade 3 disease. The HACC post-therapy stage, surgery was completed as planned after the full course of neoadjuvant therapy, so we will use the YP staging. There was no residual tumor in the negative sentinel nodes, so we have YPT0, YPN0, and we add in the SN suffix for that sentinel lymph node biopsy. Stage group will be 88 because there's no post-neoadjuvant prognostic stage tables in HACC. In the SEER summary stage 2018, it will be localized for confined to the breast. For treatment coding, surgery of the primary site will be B620 using the 2025 surgery codes. The total mastectomy is under code B600 with the removal of the uninvolved breast is B620. Scope of regional lymph node surgery will be 2 for the sentinel lymph node biopsy. RX summary reconstruction is A100. 100 tissue expanders were placed as the immediate reconstruction. The sentinel lymph nodes positive and regional nodes positive are 0, and the sentinel lymph nodes examined and regional nodes examined are both 06. 6 sentinel lymph nodes were negative on the path report. The date of sentinel lymph node biopsy is 9/2/2025, and the date of regional lymph node dissection is blank. Chemotherapy will be 03. The patient underwent the neoadjuvant chemo with multiple agents. Hormone will be 00. There was no role for the MD and for the NCCN guidelines. Hormone therapy is not given to patients with triple-negative disease. Immunotherapy will be 01. The patient had neoadjuvant and adjuvant pembrolizumab. And other therapy will be 00. Reason for no radiation will be 1 because the RT was not indicated.